Can everyone hear me okay?
Yes.
So the topic for this evening is vascular surgery for the primary care physician. And the impetus of this talk was a lot of our patients, when they have issues that may be vascular in nature, they don't go Google, vascular surgeon necessarily or look that up. They call their primary care physician. And, it's important that we have a collaboration such that our patients can have the best outcomes possible. So our goal for this evening is to understand the role a vascular surgeon can play in a primary care practice, identify common vascular diagnoses seen in the office, recognize pertinent history and physical exam findings relevant to the vascular diagnosis, and then know when to make an appropriate vascular surgery referral. I just wanted to start out by asking this question, because we get asked this a lot, what is a vascular surgeon? We've heard that a lot of times, do you do open heart? A lot of patients think that that's what we do. That's sometimes their first sort of response. But a vascular surgeon, it's a surgical subspecialty, and we're focused on doing surgical treatment of all the blood vessels of the body, outside of the cranium, outside of the pericardium. And our skill set is wide in nature. We do both open surgery, we do catheter-based endovascular and minimally invasive surgery, hybrid surgery. Hybrid surgery is a combination of both open and catheter-based. Sometimes patients will benefit from a combination of both, and so we're able to do that in one setting, sometimes under one anesthesia. And then another important thing that we're trained to do, which people don't know, is medical management of vascular disease. And I think this is a point where we could all really collaborate. It's also important to kind of recognize the value of how we can support your practice. We like to see ourselves as partners to your practice. And it's not necessarily in private practice or an independent practice, but also to a health system. We do both medical and surgical care. A lot of patients that we see don't necessarily require any type of surgical intervention, but what they do need is somebody to follow them and support you in following them. We also are proactive versus reactive. We are also trained in identifying and studying ultrasounds and abnormalities and other abnormalities on imaging studies that we order. So we often order our own studies and are able to follow issues that may be coming up. And then overall, when you put that together, I think it gives the patient the best chance for a good outcome, because we're going to be able to give them an unbiased opinion. If medical management is best for them, great. If something minimally invasive is better for them because they have a lot of other medical comorbidities, then that's the way to go. Or perhaps they benefit from open surgery or combination. So by knowing that we have this entire skill set, we can offer the patient, when it's time, the best options. So the way I kind of framed this talk was to kind of look at some common things that you might see on your schedule for the day. It's kind of a busy day. You might have patients that come in with history of a TIA or a stroke, people who complain of vertigo, dizziness. Sometimes you may order an x-ray for some abdominal pain or looking for a kidney stone, and an incidental aortic aneurysm is detected. Patients may come in with lower extremity wounds or may complain of cold or discolored feet, leg pain, leg swelling, and then looking at patients that may have kidney dysfunction as part of their medical history. So when you have a patient coming in for TIA or stroke history, one of the most important things to figure out first is, obviously, is this going to be a hemorrhagic or an ischemic event in nature? And identifying the etiology of this is important too, because there's certain things that are going to be geared towards more medical management and certain things that may go down the surgical pathway. Whether this is a cardiac, from an arrhythmia or recent MI, could this be small vessel disease intracranially from atherosclerosis? Or could this be from atherosclerotic disease anywhere from between the heart up to the brain, either in the arch, carotid arteries, or the vertebral arteries? Just by way of review, and sorry this didn't project well, just the vascular anatomy of the neck, heart's here, here's the aorta, we have our carotids coming up, they split into two. We have our internal going up to the brain and our external external supplying branches up here to the face, and then we have our verts that go back for the posterior circulation. And what we're looking at is when we're talking about atherosclerotic disease of the carotids is here at the bifurcation. And the way I like to explain it to patients is if you have a river flowing, where it splits is where the debris builds up. And that's kind of physiologically what happens. At this bifurcation, you have a disruption of the flow. And where you have this disruption of the flow, you get these little eddy currents, and that's where this plaque tends to build up because you get local injury to the blood vessel here due to the abnormal flow. We're looking at risk factors for carotid disease: age over 65, obesity, high blood pressure, high cholesterol, history of tobacco, diabetes, and family history. And then local hemodynamic factors, as I mentioned, is what can contribute to this buildup. So for your initial workup on patients like this, you want to talk to them in terms of their history, if they've had any unilateral neurological symptoms, any focal deficits, as we say, any unilateral blindness that resolves even for a short period of time. We call that amaurosis. Any evidence of prior intracranial infarct, so maybe they got a CT scan for another reason, or down the line in their history, and they've had evidence of stroke in the past. That came from somewhere, and knowing where that came from is important. And then if you have generalized risk factors for atherosclerotic disease. History of neck radiation is also important. This is a less common etiology for carotid stenosis, but it is also something that we've seen and may even need to operate on. And there's a 22% risk of greater than 70% stenosis in patients who have had prior neck radiation. In terms of physical exam findings, certainly any focal neurological deficits, carotid bruit, throwing a stethoscope on if you're still carrying one around on their neck. The sensitivity is about 60%, but just because you don't hear it doesn't necessarily mean they don't have it, but if they do have it, it should pique your interest and perhaps lead to the next steps of carotid ultrasound. Patients who have acute onset confusion or rapidly deteriorating neurological function might be having tiny infarcts from maybe an unstable plaque in their carotid, so if you're seeing patients in that way, something to pay attention to. And then just generally, and it's more for us when we see them in the office, is looking for prior neck incisions and the quality of the skin, because that's going to make changes in terms of what we decide surgically. So some imaging tests you can order for these patients straight away in the office. Bilateral carotid ultrasound is a nice, easy test. A lot of surgeons prefer this test, and it is something that we can often, if the patient's appropriate, take to the operating room. We don't necessarily need anything else. CT angiogram of the head and neck gives you more of the anatomy, more of the lay of the land. Initiating a preoperative risk assessment while they're in the office to see if they have any other additional barriers to potential intervention. Making sure that the patient's on a antiplatelet agent and a statin therapy. So I said antiplatelet agent, typically that's 81 milligram aspirin, the baby aspirin. And there's some thought about putting the patients on dual antiplatelet therapy, aspirin and Plavix. And if you look at, there's a trial that's called the CHANCE trial. This was actually done completely in China, and it was for patients within 90 days who had a CVA. When they were maintained on a dual antiplatelet therapy, they had less incidence of future CVAs. And then they did a follow-up study looking at 1 year, and that improvement lasted that 1 year. But these again are for acute strokes. So if somebody has a history, you don't necessarily need to put them on dual antiplatelet therapy, but having some antiplatelet agent and some statin therapy is important. And then you want to ensure that their medical risk factors are addressed and make an appropriate referral at that time. When do we intervene for carotid stenosis? Well, if they're less than 50% stenosis, perhaps on carotid duplex, we recommend best medical therapy, and that's, as I mentioned, modifying their risk factors. Deciding whether the patient is asymptomatic or symptomatic. Asymptomatic patients who have greater than 70 or 80% by carotid ultrasound, or if their plaque looks abnormal, and we have a habit of actually pulling up the ultrasounds and taking a look, they may qualify and benefit from surgery. And then certainly patients who are symptomatic, who are 50 to 69% or greater than 70%, should be potentially offered an intervention. So if you look at stroke risk, best medical therapy versus carotid endarterectomy, which is the gold standard for carotid stenosis in appropriate patients, Asymptomatic, 50 to 69% stenosis. Their 5-year stroke risk is about 11% with medical therapy and about 6% with surgical therapy, and that is significant. And if you look at symptomatic disease, 22 to 16%, again significant, and then the greatest is obviously the patients who have severe stenosis and who are symptomatic. They have the best improvement, medical versus surgical therapy. Sometimes you have patients in the office complaining of vertigo and dizziness. There are many reasons why people can have it, but from the vascular standpoint, this can suggest a vertebrobasilar insufficiency or a stroke in the posterior circulation near the cerebellum. So when you get a carotid duplex, part of that test does look at your vertebral arteries and can show you which way the flow is going. We want flow to go antegrade in the correct way. But sometimes you get a report back and they'll show reversal of flow. And what that means is they may have a stenosis somewhere in their subclavian or their arm arteries. So if they're in the office and you order a carotid duplex and they say, there's some flow reversal, which will show in your report, maybe ask the patient about what we call upper extremity effort fatigue, which is claudication of the arms. So a typical story will be, somebody who is right-handed, when they're brushing their teeth or combing their hair, their arms get tired faster, just like somebody who may have claudication of the legs may get tired when walking. And then, maybe have your MA, check blood pressure in both arms and see if there's any difference. So if you have these findings, they may have a stenosis somewhere in their subclavian artery. And you may also want to consider getting a more robust study, CTA, MRA, that'll give you more anatomy and better visualization of the entire system. Next thing, I want to shift to aneurysms. Actually, the most common way we're finding abdominal aortic aneurysms now are incidental in nature, and that's, you order a test for some other reason, and it's incidentally found. You can even diagnose it on an abdominal x-ray. You can see this sort of eggshell type finding, and basically it's the calcification of the wall of the aneurysm. MRI of the lumbar spine, somebody comes in with back pain or chronic back pain, gets an MRI, and an aneurysm shows up. Or a CT abdomen pelvis for any other reason. You go to the ED these days, and more often than not, you leave with a CT scan for some reason, and you may pick up an aneurysm. If you have a patient that comes in this way, I think it's important to make sure you stay on top of that patient and route them in the right way. AAA is 200,000 diagnosed yearly, 15 leading cause of death, but rupture mortality up to 90%. And even if you make it to the hospital, your mortality is extremely high, your morbidity is extremely high. So it's really critical to catch these early. Abdominal aortic aneurysms are true aneurysms versus what we call pseudoaneurysms or false aneurysms. And what that really means is that it involves the entire, all layers of the blood vessel wall, not just some layers. The infrarenal aorta is the most typical location, and that has to just do with flow dynamics. This is just a susceptible area. Average aorta in healthy subjects is about 2 centimeters. Anything above 3 centimeters is technically considered aneurysmal or ectatic, or an aneurysm. And risk factors are male gender, age over 65, history of tobacco use, hypertension, family history of aneurysms, and atherosclerosis.